corazón es un espejo que refleja lo que hay en el alma. Personalidades de Baylor St. Luke Medical Center que nos acompañan, bienvenidos. Distinguidos directores, jefes de división, áreas de servicio de los distintos hospitales nacionales e internacionales, bienvenidos todos. Personalidades de la mesa directiva de la Asociación Al-Hakim, amigos todos. Con gran alegría les doy la más cordial bienvenida en esta tarde tan lluviosa a nuestra segunda casa Centro Libanés y sede de la Asociación de Médicos de Ascendencia Libanesa Al-Hakim. Para los que no me conocen, soy presidente de la Asociación Al-Hakim, la presido por los próximos 2 años. Les doy la más cordial bienvenida. Espero que disfruten esta cena y estas conferencias con expertos ponentes. En las actividades académicas de la Asociación Al-Hakim, en colaboración con el Baylor St. Luke Medical Center, damos inicio al simposio titulado Ecocardiografía e imágenes multimodales en el diagnóstico de las enfermedades valvulares cardíacas. Contamos con 2 excelentes conferencistas que nos tienen preparadas unas ponencias de alto renombre y ellos son de renombre internacional y nos acompañan esta noche. También contamos con el apoyo de la Fundación Lilo, que soporta enfermedades cardiovasculares congénitas, aquí arriba. Muchas gracias por venir. Gracias. Siendo el corazón lo más importante para vivir, ustedes como médicos son los magos del cuerpo. Su clínica, dedicación y estudio nos prolongan y mejoran la calidad de vida. Como bien sabemos, los avances tecnológicos son sorprendentes y al ritmo de esta vanguardia hay que actualizarse día con día, por lo que hoy nos hablarán de la bomba más importante, nuestro corazón. El corazón es el motor del alma. Agradezco a todos ustedes su paciencia, su tolerancia, su presencia, que son nuestros invitados especiales. Su presencia esta noche es un honor y disfrutamos mucho de su compañía. Un corazón generoso es un tesoro incalculable. Muchas gracias. Cedo la palabra a Aida Trabulce, quien es representante de México de Baylor St. Luke Medical Center. Recibámosla con un fuerte aplauso.
Buenas noches. Es para mí un gran honor estar aquí con todos ustedes esta noche. En primer lugar, quiero expresar nuestro más profundo agradecimiento a Al-Hakim por ser los anfitriones de este simposio de Baylor St. Luke's Medical Center. Agradezco sinceramente a la doctora Emma López por abrirnos generosamente las puertas de esta prestigiosa institución y por brindarnos la oportunidad de presentarnos frente a una audiencia tan distinguida conformada por algunos de los médicos más destacados y reconocidos de México. Gracias también a cada uno de ustedes por haberse tomado el tiempo de acompañarnos esta noche. Permítanme compartirles brevemente quiénes somos. Baylor St. Luke's Medical Center es el hospital insignia de Common Spirit Health, una de las redes de salud más grandes de Estados Unidos, compuesta por más de 100 hospitales en todo Estados Unidos. Esta red opera bajo un principio que nos guía profundamente, Human Kindness, que traducido al español representa nuestro compromiso con la bondad humana como base del cuidado médico. En Baylor St. Luke's contamos con más de 24 especialidades médicas. Destacamos especialmente en cardiología al ser sede del histórico Texas Heart Institute, donde recientemente alcanzamos un logro médico, el primer trasplante robótico de corazón reportado en Estados Unidos. Somos también un centro de excelencia en el tratamiento de cáncer, Estamos reconocidos por el prestigioso National Cancer Institute y nuestro hospital integral es el Daniel L. Duncan. Nos distinguimos además en el área de trasplantes de órganos y tenemos el privilegio de estar estrechamente vinculados con uno de los centros de investigación médica más respetados del mundo, el Baylor College of Medicine. Esta noche me encuentro aquí con ustedes con una misión muy clara: ser un puente de colaboración médica y apoyar en la medida de nuestras capacidades en la atención de padecimientos complejos. A la vez, somos firmes creyentes en el valor de la educación médica continua, por lo que este simposio representa también una oportunidad para compartir conocimientos, experiencias y fortalecer lazos con la comunidad médica mexicana. Con mucho entusiasmo les presentaré ahora un breve video que resume quiénes somos y cómo trabajamos desde el Baylor St. Luke's, con un propósito claro: llevar atención médica de excelencia con un profundo sentido humano.
Take care of you. I'll take care of you. I'll take care of you.
Hola, soy Aida Trabulce, representante en México del Hospital Baylor St. Luke's Medical Center en Houston, Texas. El hospital es galardonado nacionalmente en los Estados Unidos por el US News and World Report como uno de los mejores hospitales en las siguientes especialidades: cardiología y cirugía cardiovascular. Integrando investigación clínica de vanguardia y tecnologías novedosas, el Texas Heart Institute en Baylor St. Luke's Medical Center personaliza alternativas de tratamiento y brinda acceso a las terapias más contemporáneas y novedosas para las enfermedades cardiovasculares más complejas, así como también neurología y neurocirugía, gastroenterología y cirugía gastrointestinal, geriatría, urología y cáncer, la cual cuenta con la designación como Centro Integral de Cáncer por el Instituto Nacional de Cáncer de los Estados Unidos. Si deseas más información, no dudes en contactarme. Estoy siempre a tus órdenes.
Finalmente, reitero mi más sincero agradecimiento a todos ustedes por su presencia, por su tiempo y por su calidez. Y ahora, con mucho gusto, cedo la palabra a la doctora Emma López, quien será la encargada de dar inicio formal a este gran simposio. Muchísimas gracias a todos.
Tengo el honor de presentar al doctor Sinkat Koneru, que es director de la Clínica de Válvulas, Departamento de Medicina y Cardiología del Baylor St. Luke Medical Center del Texas Heart Institute. El doctor Sinkat Koneru es director de la Clínica de Válvulas en Baylor St. Luke Medical Center y el Texas Heart Institute en Houston, Texas. Originario de la India, el doctor Koneru obtuvo título médico en la Universidad Médica de Chennai. Continuó con su formación en Australia, donde completó su residencia y especialidad de medicina interna, cardiología e intervencionismo cardíaco, antes de ir a Estados Unidos para especializarse en imagen cardiovascular avanzada en la Cleveland Clinic. Está certificado en cardiología, ecocardiografía del adulto y tomografía computarizada cardiovascular. Su enfoque clínico abarca desde la cardiología general hasta enfermedades valvulares, imagen estructural avanzada, cardiooncología y enfermedades de la aorta y microcardiopatías complejas. En el 2001 fue galardonado con el Early Career Faculty Award por su excelencia in the Patient Care of Baylor College of Medicine, reflejo de su excelencia clínica y compromiso con el cuidado del paciente. El doctor Koneru es un referente de la medicina cardiovascular moderna, integrando experiencia internacional, innovación tecnológica y una visión centrada en el paciente. Bueno, nuestro segundo ponente es el doctor Guillermo Viana Silva. Él es director de enfermedades estructurales del corazón, profesor asociado de medicina y cardiología del Baylor College of Medicine. El doctor Guillermo Viana Silva es cardiólogo intervencionista y director del programa de enfermedades estructurales del corazón en el Baylor College of Medicine en el Texas Heart Institute en Houston, Texas. Originario de Brasil, el doctor Silva obtuvo su título médico en la Universidad Federal de Río de Janeiro. Posteriormente, completó su formación en medicina interna, cardiología en Houston y realizó una subespecialidad en cardiología estructural en el Hospital General de Massachusetts, afiliado a Harvard. Está certificado en 5 disciplinas, incluyendo cardiología intervencionista, ecocardiografía y cardiología nuclear. El doctor Silva es reconocido internacionalmente por su experiencia en procedimientos mínimamente invasivos para tratar enfermedades de válvulas cardíacas como MitraClip y reemplazo valvular percutáneo. Además, ha sido pionero del uso de células madre para tratar infartos e insuficiencia cardíaca. Con más de 60 publicaciones científicas y 13 capítulos de libros, ha sido distinguido con múltiples reconocimientos, incluyendo el Star Award of Excellence in Patient Care y el premio Top Doctors en Houston. El doctor Silva combina excelencia clínica, liderazgo académico y compromiso con la innovación médica para transformar la vida de sus pacientes. Bienvenido.
Well, I want to thank everyone who invited us, and we really thank for making this work, and we really appreciate the wonderful introduction you guys gave us. Now, I'm the director of the valve clinic, so we see all the complex valves in our clinic. It's me, Silva, Dr. Kosali, Dr. Liao. We see them together. So we evaluate all of this. Our average patient population is around 75 years because it's all like non-surgical and is what we see. Okay, so I want to talk a little bit today about the tricuspid valve, and that's what we're moving forward to do the interventions on the tricuspid valve. We know the towers are up there. Everyone is doing the tower. The mitral clip, it's the same thing, the mitral valve. Now the tricuspid side is a little bit more complicated, and I want to talk a little bit on that. These are the objectives. I'm going to talk a little bit about the morphology of the tricuspid valve, the different valvular apparatus, what's the anatomy, how complex it is when compared to the other valves, and how the different imaging modalities really help us to know how we're going to approach the interventional side of things. So this is the tricuspid valve, very complex, as you can see. That's your right atrium. And you have a very large anterior leaflet, a reasonable posterior leaflet, and a small posterior leaflet, and a reasonable septal. But if you see the area here, these are all the bundles. I mean, the surgeons know this very well because they don't want to touch this area, because if they touch it, then the pacemaker is for sure. So all of the interventions, if the valve replacements, the major risk right now is compressing these nodes and having a high risk of pacemakers. So we always think about that when we do the percutaneous interventions. Again, normally you always say tri-leaflet. You see that posterior, septal, and anterior. But when you see, that's not always tri-leaflet. Sometimes you have 4 or 5. In this case, if you see this, that's the anterior papillary muscle, a very prominent, and it separates between the posterior and the anterior leaflets. So this patient has 2 anterior leaflets and 1 posterior and 1 septal. So it's always complex to understand, okay, where we are going to intervene, where the leak is coming and whatnot. And this is just a representation of Rebecca Hand's paper. Tri-leaflet is not always, tricuspid is not always 3 leaflets. Only 50% of the time it's tri-leaflet. Remaining times it's either 4 or fusion of different things. The most commonest after tri-leaflet is a fusion, 2 bicuspid posterior leaflets, 1 anterior and 1 septal. And again, the way you differentiate that is by looking at where the anterior papillary muscle is inserted. And this is a way complex, as you can see the structure of it. The anterior papillary muscle, which is larger, it supplies the cords to the anterior leaflet and posterior leaflet. The cords goes to these two from here. And these are the tiny posterior papillary muscle, which gives cords to the posterior leaflet and the septal leaflet. And you see here the septal has some small papillary muscles, but the remaining cords are attached directly to the septum. So it's a very, very complex structure. When you're actually even going in and doing a right heart cath, you would always hit one of these all the time. Now, this is a transthoracic echo. I mean, with the technology what we have with the echocardiogram, you can really know what leaflets are where just by knowing what's adjacent to it. If you're seeing an aortic valve, this is anterior. If you're seeing a septum, then septal. So likewise, you can differentiate what leaflets is what. Now, this is a multi-slice, like a 3D reconstruction of a tricuspid valve. Here, we get this three-dimensional volume, and we place an X-plane, so we understand on a short axis how many leaflets are there and where exactly is the leak coming. Because if we know that this is coming between septal and anterior, we can plan to put the clip and grasp it between those two. So it's very important for us to understand when we're doing any of these structural TEEs to really know, like, okay, how I'm going to treat the patient rather than knowing, like, how severe is the TR. And this is just to say, like, what all you need. This is so many parameters that you need to really know, like, what is the morphology of it, how severe it is, how you are going to quantify. Are you going to use the vena contracta method, or what kind of a different volumetric analysis you're going to do? Of all of that, you still have to know, is the annulus is big, or how big is the annulus, and can we do, like, anything to reduce it? Because many of the tricuspid interventional side, they are all aiming at different sides of it. Some are aiming at grabbing the leaflets, some are aiming at reducing the annulus, and some are aiming at just replacing the valve. So that's pretty cool. So this is the vena contracta this is the most easiest way of looking at it. Before we used to have just mild, moderate, severe in the tricuspid valve. We never thought about what is massive and what is torrential. The reason these two came up is because if we are intervening on this tricuspid valve, if we reduce from torrential to severe, it's like dropping down a significant volume of blood going into the right atrium. So the patient gets significantly better, even though the patient still has severe tricuspid valve regurgitation. It's always depends on how much you're reducing it. If you're reducing into half of what the leak is, that's all it needs for patients to improve. And these are the different techniques. We mainly use in our lab the 3D vena contracta. So we use the 3D volumes, and from there we measure the amount of leak, and we go from there. So this is just to see the prevalence of it, like how prevalent it is. And you see here, this is all the three valves combined, but after age 65, just the tricuspid valve, the prevalence goes up. And if you see the tricuspid valve, the main problem with the tricuspid valve regurgitation is all left-sided. Almost 50% is left-sided valve problem, either because of mitral valve, mitral stenosis, mitral regurgitation, aortic valve regurgitation, or aortic valve stenosis. And the remaining 23% is pulmonary hypertension and LV dysfunction. So always when you see a tricuspid valve regurgitation, don't just ignore what's happening on the other side of the room. And here, almost 90% is secondary. It's because of the left-sided problems or pulmonary hypertension. And we do see nowadays the primary TR, where you see the caudal bead ruptured, or there is a valve problems. It's mainly because nowadays we're seeing more of this tricuspid valve lead endocarditis, where the leads are taken off, so the cords are getting ruptured, and then you see tricuspid valve regurgitation being severe. And this is one of the example like post-lead extraction, you see the cord being ruptured and causing significant TR. This is the same patient. You see the cord being ruptured there, and then you see all the leak getting into the ventricle, showing like, still the vena contracta is 1.3, still sitting in the severe range. This is just a 3D representation showing like, how the leak is coming from which area. Now, the secondary MR, as we already talked, like it's mainly because of the left-sided, it's easy to see because the annulus enlarges. And I'm going to talk about like how it's going to enlarge in which side it is. And it gives a very wide, a wide-based, unrestricted leak. And this is a very, very big leak, right? So we always go to transgastric views on a TEE to know how many leaflets the patient has. You see, this is like 2 anterior leaflets. This is A1, A2. This is posterior, and this is septal. It's very complex to understand before we go for intervention. We think a lot, we do a lot of these things because we just want to know exactly, because we don't want to go and like clip these two while the leak is between the anterior and the septal. So, and the 3D echo really helps. This is the transgastric view of all those leaflets we talked about, and you can see clearly the central non-cooptation. And we know that like, grasping these leaflets are really going to help to reduce the leak. So, and this is just a representation of the color Doppler showing how much of the leak it is. Now, this is where I was talking about when you have an enlargement of the atrium, then it enlarges laterally along the anterior and posterior leaflets. As the atrium enlarges, the ventricle enlarges, the annulus goes with it. And also the septum, it goes towards the left side. So as this all enlarges, you will have a central void which gives rise to the secondary tricuspid valve regurgitation. There are so many studies which have shown that if you are in sinus rhythm, that's how it enlarges. But if you're not, then it mainly goes posteriorly and enlarges in the posterior annular side. It's just for us to understand if there is an atrial fibrillation, then you mainly grasp the posterior and the septal leaflets versus grasping the anterior and the septal leaflets. And how is multimodality, how is the CT and the MRI is going to help here? Now, we see in a normal TEEs, we clearly see like how that pacemaker is placed. Is it adhered to one of these leaflets? Do we have to take away the lead being attached to it? And we see it like very clearly. But sometimes you need like a 3D reconstruction. If you see in this particular case, the atrial lead is sutured directly into the anterior leaflet. Because in the pacemaker people, the EP guys, they just look at it on the fluoro and they don't know where they're screwing. As far as there is enough potential, they'll just screw it there. So that's what happened here. They screwed here right onto the anterior leaflet and causing a severe TR. Now this is again a CT scan. Like you can see how it's sutured right onto the leaflet. And that's your annulus, that's the right coronary artery. And you can see the atrial lead sutured right into the atrial septal. And this is a 3D, if you can imagine. That's the atrium there, that's the annulus, and that's your right ventricle, okay? And you see how the lead is coming and attached to the anterior leaflet. I just want to show you like how you can see it in a CT scan on a full volume, that how nicely you can show that the lead coming and attaching to the anterior leaflet. And this is another example where the electrophysiologist want to get an RVOT pacing, and you see the leaflet there. It's almost pinned onto the septum, leaving this leaflet coming in, but a central large void, which is causing like severe tricuspid valve regurgitation. But they only say that it's 5% of the cases of the tricuspid valve regurgitation is because of the pacemaker. But we see a lot of this. Now again, this case is very interesting. It's not just that you see the hepatic vein flow reversal, you see in the tricuspid valve regurgitation. You see also that in CT. See, the contrast is getting back into the hepatic vein, right from the tricuspid valve, right there. The contrast is filling backwards into the hepatic vein and to the liver. It shows like how severe is the tricuspid valve regurgitation is. And this is just another picture of the CT. We can measure the volumes, and I'll tell about like why we have to be really concentrating on the right ventricle. And again, in this case, if you see, there's a flail of the septal leaflet with a wide gap here, just causing the severe tricuspid valve regurgitation. Now, what's the importance of right ventricle? I want you guys to think about like the way you think for the mitral valve regurgitation and the left ventricle. If the left ventricle is poor, very low function, if you fix that mitral valve, the patient is going to fail and he's not going to come back. It's exactly the same mechanism happens here. There is a very good trial which has seen they divided into 4 groups, one with severe TR, with a normal function, the patient is asymptomatic, one with the RV dysfunction but no symptoms, one with RV dysfunction but the symptoms are controlled by medications, and one with refractory with the medications. So these 4 groups, when they're seeing the outcomes, the patients who have RV dysfunction and any symptoms did very poor. And it tells you that any TR, if we are catching them late, it's pointless to even chasing them. It's very late. We already caught them in a very late situation. So that's where it's very important. If you see a tricuspid valve regurgitation, you got to act quickly before the patient goes in failure. And again, this is just a representation showing how the tricuspid valve severity, whether you go with different modes, whether it's vena contracta method, regurgitant volume method, or any method you use, the more the severity is, the worse the prognosis. And it again shows here, anything more than moderate, the prognosis is worse. So the tricuspid valve is always a forgotten valve, but I think we need to start like looking at it more keenly and early enough. So how do you measure the RV and RV function? It's very hard on the echo. Like, you see that, it's very hard to know, okay, this RV is normal or not. Different views, it shows in a different way. But the 3D volumes measuring is one of the probably getting closer along with the RV strain, but this is not that easy. In patients with RV failure, you can't see this very clear contours to make it, right? So that's when you always have to go to the next modality, which is cardiac MRI. So in MRI, not just the volume and function we see, we also see the leaflets. How many leaflets are there? We can know where the leak is coming and how severe it is. This is just a normal patient to represent like how we do it. So we measure it in systole and diastole, like the way we measure the Simpsons for LV. We measure throughout the cardiac cycle. We get the stroke volume, and we use a phase contrast imaging where we measure the stroke volume directly from the pulmonary vein. So the difference between these two is the tricuspid valve regurgitation. So it's a very precise way to know what's the function of the heart, what's the volumes, and how you're going to make a volumetric analysis and everything. If you see that the RV dysfunction is more than moderate, you have a pulmonary hypertension, I think that's it. I don't think we can go any further. The patient should be just treated medically. So now coming to the surgical data, if you see almost 86% of the time, the surgeons only treat the tricuspid valve when they are approaching the left-sided problem. If they're approaching the aortic valve, if they're approaching the tricuspid valve, approaching the mitral valve, then they come back and do it. But if you see the isolated tricuspid valve surgeries have almost 9% mortality. It's because they were referred late, and that was the main problem. Now again, almost 40% of them, the surgery is non-elective because the patient is sick, and we all want to help the patient, and that's why we go ahead and do it, and it's too late already, right? So, and it's been clearly shown whether you replace it or repair it, the mortality is still the same, and it gets worse in 5 years and 10 years, equally bad. And when you have a redo of this, the mortality goes up to 37%. So all of these tells us, that we need something that we should do like a minimally invasive to get away with this, because these patients with that RV load, they can't have enough reserve for the RV to recover post-surgery. Because you're going to close that valve, all the volume is falling back onto the RV, and the RV is going to fail, unless you act early when there is an RV reserve. Okay? And this is just a representation showing whether it's repair or replacement, it's almost 12% mortality there in surgical patients. Now, coming to, I just want to touch base with very few of these. I just don't want to go in depth of this. There's so many of these trials are now going on. We are involved with few of those in our center, but some of them are aiming at closing the leaflets, like a co-optation device. Some are aiming at stopping the leak to go through the IVC so they can stop the congestion of the organs. But let's talk about the tricuspid edge-to-edge repairs. Again, when we are evaluating a patient, we do all these modalities because we don't know which side we're going to go. We don't know if we are going to offer the patient edge-to-edge repair or we're going to offer the patient like valve replacement or repair. So this is a case how we deal with the tricuspid valve edge-to-edge repair. We get the 3D volume. We will see where the leaflets are, and we put a color. We see the majority of the leak is between anterior and septal. So once we know this is the clip device, so we advance the clip device right across where we saw the leak. We make sure that these leaflets fall right onto the grasping areas. And then once we know, then we go to transgastric again, reconfirm that that's exactly where we want to grasp them. And finally, once we see that, we leave the grasping, the graspers down, and that's when you can see the tethering on both the sides. And then we go ahead, we close it. If we have even moderate of TR, we are really happy. We'll just leave the patient there. We don't aim at correcting it 100%. And this is a triluminate trial for the tricuspid valve clip. This is a very good trial, which is randomized 350 patients between edge-to-edge repair and the tricuspid valve alone. And you see there is no difference between death or hospitalization. But what changed is the patient's quality of life. It significantly improved. And it reduced almost 87% of the patients, the TR was moderate. And it has shown that as you reduce the TR more than 2, the quality of life parameters improved significantly. So the authors were like, the tricuspid edge-to-edge repair is safe, and it reduces the TR, and it improves the quality of life. So this trial was released in 1.5 years ago, and immediately it's now approved in US. So we have the opportunity to use this TriClip for the tricuspid valve and treat these patients. And there are so many other trials going on with various different modalities. I don't want to go through a very complex of these devices, but I want to show you how the cable devices are used. This is a very interesting one where you can just place one device here, isolating the leak from the right atrium. So all of the congestion of the liver and the kidneys and the colon, it all be recovered, and the patient feels a lot better. So many of the trials, they use the Edwards valve, and this is the heterotropic cable valve. You can see how it sits right above it. We have to include the hepatic vein below that, so we will make sure none of this is leaking back into the veins. And this is a very intuitive way of looking at things. And this is an orthotopic transplant. And this is a Navigate. It's still in the clinical trial. These are the trials I was like, exposed to see some of these when I was in the Cleveland Clinic. This is a direct deployment of the navigate valve inside the tricuspid valve. This is, again, it's not uncommon. I think so many places, I'm sure they're doing it here, where you have this bioprosthetic tricuspid valve, very calcified and stenosed. And once we place the TAVR valve inside it, you can see how nicely the valve is opening. And this is, I think, is a very common thing that people do everywhere right now. Now, the Evoke system is the other, and the last one I want to touch base here. This is the device where it grasps the cords and it stabilizes by itself by sticking there. And the valve will be right at the center, which functions like a normal valve. Now, the TRISCEND trial was done in all patients who have more than moderate TR. They followed up for 1 year, and they've seen almost 97% of the time the TR improved. So it completely corrects the TR. So you have to be extremely careful that the patients who have RV dysfunction, if you get them the valve, they're going to fail because there is no leak. The load falls onto the RV completely. So again, when compared to the KCCQ, markedly increased KCCQ, and the patients felt a lot better, and that's approved now. It's an FDA-approved valve right now, the only valve which is approved for percutaneous valve therapy, and we are going to get our hands on to it pretty soon. Again, want to emphasize, there are so many other trials are going on, but right now it's only the TriClip and the Edwards valve which is available for us right now. So in summary, the tricuspid valve is complex than mitral valve, and as you see, more than 90% you got to blame the left side. Medical management leads to a higher mortality because you're going to delay the care of the patient, and the almost 9% is death surgically, and almost more than 30% when you do a redo. The edge-to-edge technique is approved right now, and so is the Evoke tricuspid valve replacement. Thank you so much. This is my email. Please feel free to send me the images, echoes, anything. I'm happy to help, happy to discuss. I'm happy to share my mobile number. Just feel free and text me, and please let us know if there is anything we can help and do. Thank you.
Thank you again for having us tonight. It's been a pleasure to meet all of you and to meet old friends like Dr. Solana. I was saying that you guys now know why we work together, why we fight like cats and dogs sometimes, me and Conero, over what we should do with the patients, but above all, we have a very collegial relationship. So I would like to start this by, Srikanth, take a look at this. This is for you. So there are 3 ways to describe the relationship between an invasive echocardiographer and a structural interventionist, okay? So, and I'm not politically correct, so you guys are gonna pardon me. But he's an invasive echocardiographer, but he's also an interventional cardiologist, as you saw. So this is how I feel sometimes, I'm the lady running, I don't see anything, and he's the one guiding me. You see that? And in fact, once you think about it, she's the one theoretically competing, but this guy is doing as much work or even more than she is, right? So the other way that I see this is I'm the driver in Le Mans and 24 hours, and he's the co-pilot there, and he's saying, shit, go on, man, come on, go faster, 55, 57, yeah, hell yeah, there you go, 3 seconds quicker. He's like, he always wants me to go faster and faster and faster because his back is hurting. Or, this is how I feel sometimes in the cath lab. I see everything, I'm like, oh, that's great. And this is what happens next, he turns it off. he changes the view to wherever he wants to go because he thinks, oh, no, this is not important. I'm like, man, I need to see where I'm going. So without him, this presentation wouldn't be possible. Without all the nurse practitioners, PAs, MAs, this is a team approach. This is not me, but I get to be lucky and come down here and talk to you guys. So I'd like to start by, there's a microphone in the middle of your table, and it does not burn you. It's very, very cold. So you guys can, each table has a microphone, and we can participate. I'm going to ask questions, and they're not tricky questions. They're just very, very simple questions. So I had this patient, 97-year-old gentleman, working full-time. He's a judge with severe AS, New York Heart Class Association 4, bad medical history, like, DVT, moderate COPD, hyperlipidemia, had a renal cell carcinoma, now has he does have a suprapubic catheter, and a really bad EF, and a GFR of 27. And this guy is 97, but he works full-time, okay? So he's a judge again, he goes to the office, and he's not retired. So I'm like, and they're concerned about dialysis. They don't want to do dialysis. So we go in, we take like 3 pictures, one of the left, nothing going on, and one of the right. And then we do an echocardiogram and a TEE as well. So who's the imager here? The gentleman back there, yeah. How bad is this MR?
It's truly calcified and
The aortic valve, you can talk in Spanish actually.
la válvula aórtica está severamente calcificada. Todavía conserva cierta apertura de las valvas, pero pues condición estenosis severa.
¿Y la válvula mitral cómo está? ¿Está muy mala? No está tan severa, ¿sí, no? La fuga mitral no está
Moderada.
moderada. Sí, moderada, leve moderada. Y acá está el 3D. Y no está mal. So what do we do next? ¿Cómo? No tengo el diámetro. No tengo. Pero que, take my word, it's mild to moderate by all the measurements. So what did we do? So he didn't want to have dialysis, so we did a non-contrast cardiac MRI, and that's where, the imager comes in, right? We can see here that you can with a non-contrast cardiac MRI, we could measure everything that we needed in the root, size in the valve, the takeoff of the coronaries, etc. It doesn't give us the calcium in the LVOT, but it gives us most of it. We did a non-contrast CT to look at the size of the vessels, and this is what we did. You see here, in the left side, we did a TAVR guided by TE and fluoroscopy only. So this is the predilation with the balloon. And to do this, it's a lot. You cannot do this with an Edwards valve. Or you can, we probably shouldn't. You should do this with a self-expandable valve because you can always recapture if it's not in the good position. So I have the luxury of having him do this whenever he's in a good mood, actually. But so basically, it's essentially deploying the core valve now. Core valve looks great, guided by TEE. Fluoroscopy time, 8 minutes. No contrast, no transfusion, blood loss less than 15 cc's. We're all happy. We're high-fiving each other and doing great. No significant PVL. Extubated in the CVOR. Did very well for 48 hours. Then had pulmonary edema. respiratory failure and required reintubation. Anybody want to take what's happened? En
The
español.
mitral valve got
No.
worse.
Dr. Solana, you cannot talk. No, no puedes hablar, Dr. Solana. No, por favor. Okay, Jesus Christ. It took me hours to discover this. Okay. All right, so this is post-TAVR. Look at that.
Severe mitral regurgitation.
Severe mitral regurgitation. Why? ¿Por qué?
That's a ruptured valve.
No me parece que sea rupture. It could be.
It's a core valve. Maybe it's too deep and it's interfering with the mitral valve.
You can say it in Spanish. Está bien.
Bueno, aquí decimos que está muy metida o está muy profunda la core valve. Y pues
Exactamente. No existía posibilidad de hacerla más. It was too deep. We could not put it in the right position because the annulus was too big and the LVOT was too big. So the position that the core valve could be is that one. What I didn't show you is that we deployed this valve 3 times. Okay? So what do we do next? So pre-TAVR.
Just one. It just shows, right, like how the heart is made. It's not the aortic valve is separate from the mitral valve is separate. It's all together. You know, if you put the valve there, it's almost onto the aortomitral curtain, and the cooptation is completely gone wrong here. So if the flail was there even before. The reason why you have an MR now severe is because the cooptation is malaligned. Just because you change the way it is sitting there. So it just shows like how amazing heart is.
So here we go. So this is what we did. We did a mitral clip. The next day, and this is what we got. A lot better. So patient did really well. Very little MR residual. The LA pressure went from 38 to 17 mean, and this is the final result. The next case, can somebody take the microphone from Dr. Solana, please? Okay, 2022, 86-year-old man with severe aortic stenosis, chronic kidney disease. You can see a pattern here, right? We cannot do anything simple. Prostate cancer, hyperlipidemia, hypertension, diastolic dysfunction, classical symptoms of severe AS, dizziness, pre-syncope and syncope. Echocardiogram, mean transvalvular gradient of 40, and severe aortic stenosis with severe aortic valve calcification. So, ¿qué te parece esa válvula? Con ese calcio.
Tiene una enfermedad arterial periférica muy importante, prácticamente toda la aorta
Hable un
abdominal.
poco más alto para que le escuche.
La aorta abdominal y las ilíacas femorales, todo está totalmente calcificado. E igualmente, más a nivel de la válvula aórtica también con una calcificación muy importante.
Sí, se ve aquí en el LVOT, el tracto de salida del ventrículo izquierdo, que también tiene un calcio importante. Acá está el CT scan. Agatston score of 6,000. So, would you like to do anesthesia for this? Doctor, sí, puede hablar. ¿Cómo? ¿Quiere hacer anestesia?
Bueno, sí hemos manejado casos similares.
Ajá.
Esto
Hable más alto, que no escucho bien.
Hemos manejado algún caso similar, no con la comorbilidad que como en este caso se ilustra, estenosis aórtica severa, ¿sí? Para la colocación de una válvula transcatéter. Y bueno, pues hemos manejado las dos modalidades, ¿sí? Con sedación o con anestesia general. Nos da opción dependiendo de la comorbilidad.
Sí, es verdad.
Sí.
Es verdad. A mí me parece que ese caso es más de anestesia general porque tiene un calcio en el VOT. Entonces, ¿qué tipo de válvula vamos a poner aquí? ¿Voy a hablar?
¿Alguien más?
¿Alguien? Core valve versus Edwards. Let's take a vote. No? No votes?
Tiene calcificación severa del LVOT, alto riesgo de fuga paravalvular, riesgo de pacemaker y riesgo de ruptura anular. Yo pienso que es para una autoexpandible por todo esto. Sí,
Yep, I agree 100%. So tread lightly, that's how we say. So general anesthesia, advanced stage frailty. So we did a sapien valve. And good result, the valve expanded. There's a little bit of a ding in the top part there. You know, I want to blame the fellow for the wire to come back, but no, that's me. I did it. And so unfortunately, he had, because of the calcium, he had mild to moderate paravalvular leak. Okay? So we ballooned this valve again twice. And we were not happy with the leak, but you know, he's 86, frail. He's not wheelchair bound, but he walks very little. It was a great result for him. We did look at the hemodynamics. You know, to your right, you're going to see here that by hemodynamics, the AR is not significant. There's no diastolic equalization. You know, the LV was doing great. So we said, okay, let's leave it alone, and let's go from there.
But to your point, you see the ECG.
Can you give him the microphone, because he doesn't talk loud, yeah.
You see the ECGs, to your point. It's widened, you know. So that's a risk you pointed out.
Yep. So what next? What happened next? Dr. Solana, don't talk. So we looked at this guy 1 month post-valve, doing great. The gradient was somewhere between 8 to 16. You know, he was doing okay. Fast forward 10 months, okay? Worsening dyspnea. And what was worse was not even the shortness of breath, was hemolytic anemia. This guy was getting transfused like every month. He was getting 1 to 2 pints of blood. Have you guys seen that? Anybody saw that with paravalvular leak in TAVR? No? Dr. Solana, now you can talk. Yeah?
Yes. Especially with hemolytic anemia. With the hemolytic anemia, we have seen patients like that.
Yeah. So apparently 5% of the patients that have significant PVL are the ones that have hemolytic anemia. Otherwise, you don't have any problems. You know, of course, this guy had it. And look at the valve. The valve degenerated. Lots of calcium. And now, you know, the valve obstructed again. And here's the TEE. Anybody wants to talk about the TEE? Maybe the anesthesiologist that's texting. Emma? Emma? No problem. Want to talk about the TEE? What do you think? Dé un micrófono.
¿Cuál es la pregunta?
No, pero le está preguntando.
¿Qué le parece a la válvula?
Pues mal, ¿no?
Mal, ¿sí? Y tiene fuga también valvar, también. No
Sí,
es solamente
claro.
perivalvar. It's not only perivalvular leak, it's also valvular
Paravalvular
now.
aórtica.
Eh,
Pues yo le hablo a él. Bien, pero sí se puede.
sí se puede.
Claro, todo se puede. No, se puede, se puede. Le pones poquito, vas poco a poco.
Okay. And that's the surgeon there. That's I'm sorry, I don't know your name. Him.
Tú.
Do you want to operate on this patient?
86.
Si empezó con 97, fue al 98, ¿cuál 86?
Now this one is 86. Esse tem 86 anos com frailty. Severe frailty. Moderate to severe frailty. Would you operate on this guy?
I don't know. Probablemente habrá que ver cómo está su morbilidad ahora porque antes ya tenía falla renal y creo.
La movilidad está terrible. Si no caminaba mucho antes, ahora no camina para nada.
Sí.
Que tiene falta del aire, no está bien.
Sí, ponerle un valve inval probablemente.
Sí, mi cirujano tuve la misma reacción que tú estás teniendo ahora. Dije, hell no. You know, and that was Dr. Joe Coselli that you probably know. Coselli looked at him and said, no, I'm not going to take him. So I had to show this because he likes to show off too. He does this little thing, I don't know, what is this tree? What is the name of this? Glass? Yeah. And you see that you have, you know, to the right side there, you have the paravalvular leak. So we thought, wow, look, this patient now has moderate stenosis, degenerative valve, severe prosthetic valve regurgitation, but now also has an eccentric paravalvular regurgitation that with anemia. So what are we going to do for him? Surgery is not possible, right? If we put in a new valve is this going to help him? Put in a sapien valve, for example, here. Do you think it's going to help him? Dr. Solana, your partner, the boss, la jefa, what do you think? ¿Qué te parece? ¿Va a mejorar? ¿Va a ayudar al paciente en una válvula Edwards o no?
No, tiene insuficiencia mitral, aórtica severa.
Severa. No va a ayudar porque no va a expandir, que es una válvula que ahora está muy mala, tiene mucho calcio, tenía mucho calcio antes, ahora no abre. Entonces, muy probablemente necesitamos hacer algo diferente. También tiene una fuga perivalvar bastante significativa. Entonces, lo que hicimos es eso. So, heart team and said, let's do the paravalvular leak closure and then put a new valve in. So this is what we did. We crossed the paravalvular leak with a multipurpose guide, glide catheter, telescoping fashion, and we put in I think it was a Amplas vascular plug. I think it was a AVP2. I think it was an 8. This is the AVP2. I call this the S'mores device with great result. And then we decided to put a self-expanding core valve, and the patient did great. And we were lucky because his coronaries takeoff were high enough that we would not interfere with the coronaries. He's doing great. This guy is literally, you know, doing really, really well. And he needed a micro though. So, actually, I'm sorry, you're right. There's one thing that happened right here that was very dramatic. He had a suicide ventricle. He developed a hypercontractile left ventricular state with systolic anterior motion of the mitral valve, LVOT obstruction with severe MR, hypotension, and so we actually had to give him a lot of phenylephrine and fluids. And we also had to pace him, which he got a micra. That also helped with his LVOT obstruction, pacing him. And he stayed in the unit for a while. Do you remember history, or you want to swallow and then talk? want to comment on the suicide ventricle?
Yes, most of these patients, when you have like a small ventricle, when we relieve the thing, they just have SAM, and they have like all of these problems going on. You know, if you go back, what really helped in this patient is left bundle branch block and complete heart block. Because when we start to pace, you're pacing the RV, and the RV comes out of the septum, and it starts to relieve the LVOT. And that kind of end, what we do is we lower the heart rate by the pacemaker to 50. And when we do that, it lets the LV to fill in, and it relieves the pacing. So it took for us, like, we loaded with 4 or 5 liters, lowered the heart rate, and then he started to get better. So it took us, like, either me or him, we directly were there in the CCU, almost all like 4 or 5 days, until the guy got better.
This guy's walking. Amazing. And this is 1 day. This is 1 month. It's been a year already since since this happened. Are you ready for one more? Are we tired? Are we good? Okay. 78-year-old with a history of hypertension, CABG, limited LAD, SVG to the PDA, severe AS, and had a SAVR with a 27 mosaic with a true ID of 24 in 2001, and then had a valve-in-valve with a 26 Sapien XT in 2016. Presented with worsening dyspnea exertion and has found to have a really bad, actually stage 1, ascending colon adenocarcinoma, needed surgery. So nobody would touch him surgically, and he needed surgery for his cancer. So this is a baseline. So you see here that this is the baseline right after the procedure. You see here that mean gradient is 50. This was before, 55. And this is now. So the heart cath showed a mid-LAD CTO, patent limited LAD, circ without significant disease, mid-RCA, 70% stenosis. This is the right heart cath, PA pressure of 74, mean PA pressure of 50. So PVR of 4 Wood units. This guy is very, very sick. So this is his cardiac CT. You see here there's a lot of calcium too in this valve. So I was very concerned because the mosaic is, you can break the mosaic, but there's a Sapien XT in there and there's calcium in the valve. And this is, so thankfully we had good iliacs, but not fantastic, but kind of good iliacs to work with. So this is what we did. We thought that to get a better hemodynamic, we would need to break this valve. I was very concerned that there was circumferential calcium outside the valve. So and this patient had a low EF and with a PA pressure in the 70s. So if he had, cardiogenic shock, an Impella would not be enough because he had very high PA pressures. So we put him on VA ECMO. We put in a Sentinel device because we're going to break this. And then we used 2 shockwave balloons, and it's a shame because we did not see any of the shockwave balloons. 2 shockwave balloons at the same time before we even ballooned the valve. So VA ECMO, shockwave with 2 6.5 by 60 shockwave balloons. So whenever we shockwave ballooning, we're essentially occluding completely the flow across the aortic valve. So that's why we also needed him on VA ECMO to support him while we're doing it. And then we fracture it with a 24 balloon and put a 23 Sapien. This is the Sentinel device. The shock wave, we didn't see it well. And this is the fracture. We fractured before, and then we put the valve in. So 3-month follow-up, low normal EF, 50-55, peak gradient of 36, mean gradient of 16. He did have his colon, and is doing really well. That's it. One more case just for the road. This is one that I don't understand really well, but I'll get Cornero to explain to us. So this case here is an example of valves that we probably shouldn't do with clips. Anybody wants to talk about this valve? Cornero, want to talk about it? No? Okay. This is a patient with Marfan's, with really bad prolapse, and was not considered a surgical candidate.
Can someone see there are two clips there?
This is an unsuccessful clip.
We placed 2 clips already, and he needs probably another 4 clips.
Yeah. This guy went to surgery.
Yeah.
He went to surgery about a month after those clips, and he didn't make it. And he was young. I think he was like 42. Yeah. So the surgeon didn't want to operate on him, and that's why they asked us to do a clip. But clips, but take this into account too. This is the old clip. Okay, this is the short clip.
Yeah.
We didn't have XC at that time. So
and also the newer Pascal clip.
Yeah.
Which is, so the Marfan's, the main problem is the collagen. We try to grasp it, it tears off. It doesn't stick to it the way we normally. The new Pascal device, the clip, it actually makes the valve to sit in there, and it really closes it off. It brings the things together. So the Pascal device is good, but this probably 2018 or I don't know.
Yeah.
We did it like when the clips were really the first generation.
Okay, so this is a very, very difficult patient. This is a congenital patient. This patient has dextrocardia. This is what he has. So he has atrioventricular endocardial cushion defects. He has a VSD and an ASD that's huge, so he got like a common atria. He's got a vestigial left ventricle, and so the RV is actually the systemic ventricle. So essentially, he's got one big valve that is in between both ventricles and this common atria. And you see here down that this anatomy is also quite interesting because the common AV valve has like 6 or 5 portions. There's also a variation in the anatomy, but this is what we're looking at. Do you want to show them?
Yes. So on the left side, that's the rudimentary LV, and on the right side, what you're seeing is the morphological RV, but that's the systemic RV, which is pushing all the blood out. You see right at the center, that's the intraventricular septum, and you can see the whole defect.
The VSC is right here. Yeah.
Above that, and yeah, it's a continuum.
So
a large VSD defect, like hypoplastic LV, the single ventricle physiology, and you have one single valve all through, and it is leaking. We never get time to publish. In United States, we are the first to do a congenital clip. But UCLA published that they did the first. But in records, it says.
Yeah, so what this patient had was Watterson-Cooley shunt. So it's a shunt from the SVC to the right PA to give the pulmonary vasculature some blood, and also had some ablations, and was not a candidate for anything. So this is a team. So what's really important here is the collaboration, right? So you see here the Dr. Nair. You guys know Dr. Nair? That had didn't he do the yeah. And then so Dr. Nair, Dr. Alam, Strickman, yours truly, Dr. Simpson, that's leaving us, Dr. Conero, Dr. Perec is also, and Dr. Diaz. So doing this clip is like this. It's like driving a stick shift in Britain. You know, yeah, everything's in the wrong side. You see here, the clip is facing the complete wrong side. So we actually were able to put 2 clips in. Well guided. And the patient did really well. She was actually on oxygen. And she got off oxygen. So you see here what it was before. This is after, with the 2 clips here. And that's all I've got. Thank you very much.
Bueno, démosle un gran aplauso al doctor Coneru y al doctor Silva, por favor. Muchísimas gracias. Excelentes ponencias. Muchísimas gracias por su participación, por su presencia, por enaltecer este evento. Agradezco especialmente a las personalidades del Baylor St. Luke Medical Center por la oportunidad de esta colaboración. Agradezco a todos ustedes, distinguidos directores, jefes de división, áreas de servicio de distintos hospitales nacionales e internacionales que nos acompañan esta noche. Y también agradezco a las personalidades de la mesa directiva de la Asociación de Al-Hakim que hoy nos acompañan. Así pues, quiero recordarles el apoyo a la Fundación Lilo que hoy nos acompañan aquí, por favor, que nos ayuden a difundirlo y si quieren comprar algún osito, alguna playera, alguna pulsera, algo para apoyar a la Fundación Lilo, se los agradecemos especialmente, que es para apoyar a personas con enfermedades cardiovasculares congénitas. Así pues, le cedo la palabra una vez más a Aida Trabulce, representante médico de St. Baylor Luke, para que nos dé finalmente unas palabras de cierre. Muchas gracias.
Pues no me queda más que agradecer. Amé su participación, amé que el doctor Silva los hizo participar, todos estaban súper concentrados, el doctor Coneru compartiendo, tratándoles de explicar que todos ya sabíamos qué hacer, había casos complejos, difíciles, bueno yo no, ¿verdad? Casos complejos, difíciles, todos súper concentrados, interesados en los temas. Les agradezco muchísimo su participación, el haberse esperado, su paciencia. Empezamos 1 hora tarde para tratar de que llegaran las personas que faltaban, que nos comentaban que venían para acá y quisimos darles un poco más de tiempo por el clima que estuvo inadecuado, pero a todos los que llegaron a tiempo y en tiempo, Les agradezco su compromiso y su cariño, porque sé que muchos vinieron por cariño a estar aquí con nosotros y compartir estos momentos. Muchas gracias a todos. Repito, el doctor Coneru y el doctor Silva comentaron que si necesitan sus datos, por favor se acerquen con ellos. Cualquier caso complejo que tengan y que tengan alguna duda, ellos más que abiertos a que les llamen, les manden un mensaje, les manden sus casos y encantados les pueden ayudar.